Between 500,000 and 4 million children in the United States are labeled hyperactive. They have earned this label because they behave in ways that are driven and uncontrolled. Many suffer from a short attention span, throw frequent temper tantrums, have trouble sleeping, and experience learning difficulties in school. The most common treatment for hyperactivity is to prescribe an amphetamine. Amphetamines are stimulants that paradoxically seem to control the symptoms of hyperactivity in some children. Dr. Sidney Walker, a neuropsychiatrist who practices in La Jolla, California, believes that treatment with stimulants is never justifiable. He argues that hyperactivity is not a disease, but a constellation of symptoms that can have many different underlying causes. These causes may be biochemical, neurological, physiological, psychiatric, or situational. Dr. Walker feels that physicians must examine hyperactive children more thoroughly than they usually do in order to determine the correct diagnosis of the underlying disorder. Once a proper diagnosis is reached, he says, the individual child's particular problem can be treated appropriately, almost always with success. Dr. Walker talks about hyperactivity with Psychology Today editor Dr. Carole Offir.
Dr. Walker, what kinds of children are labeled hyperactive?
Well, typically the label of the hyperactive child can stem from several sources. So hyperactive might be a label placed on a child by the teacher, which would be characterized as a child who could not pay attention in the classroom, a child who may be disruptive in the classroom, or the child who is not quite performing up to standard of the rest of the class and therefore considered disruptive. Hyperactivity as seen by a parent might be the child who is a discipline problem, or the child who is destructive at home, or the one that is unable to get along with his sibs. In determining hyperactivity, you have to consider the source of who's making the value judgment. For a physician, a hyperactive child should fulfill the criteria of demonstrating by history-driven behavior, who may or may not have interruption of his sleep pattern, who is destructive not only to his toys and surroundings, but in some instances to himself, who has difficulty with peer relationships, and who may or may not be having frank school difficulties.
All right, so a learning disability or learning problem in and of itself is something independent from the hyperactivity. That is, it may or may not accompany.
That's right. There may be hyperactivity as a function of the learning difficulty, though all children's learning difficulties do not demonstrate hyperactivity.
A number of people have questioned the whole concept of the hyperactivity syndrome and have proposed that these are simply children who have a slightly higher energy level or a little bit more active. Is there a real qualitative difference between the children you see and the simply normally active youngster?
Yes, I think it is a subtle difference, but the main issue, I think, is in terms of semantics, that hyperactivity must be looked at as a symptom and not a disease or a syndrome, really, in that there are many explanations for the symptom of hyperactivity. To look at hyperactivity as a disease is the first error, because there isn't just one thing causing it. However, if you look at it as a symptom and put it together with a sorting through of other symptoms that go into describing this value judgment of hyperactivity, then you come up with a constellation of data that leads you to information about the central nervous system imbalance. And basically, hyperactivity is an expression of the central nervous system not functioning properly.
Assuming that there really is something physically wrong with the child, then...
Well, all hyperactivity is not just a function of physical disease. Hyperactivity can be certainly emotional, situational.
What usually happens to a child who's hyperactive? When is his hyperactivity usually detected? It is usually a boy, right? More often a boy than a girl.
Very frequently a boy, though female children are not immune to the syndrome, or the symptom, I should say. The detection is usually after the first, second, or third year of school.
Now, suppose the teacher decides that a child in her classroom is hyperactive. What usually happens after that?
The teacher then will typically bring pressure to bear upon the parent, and not infrequently issue an ultimatum that the child cannot return to class until he either, frankly, is put on medication. The parent then is forced to go to the family doctor or the pediatrician and relate that the teacher will not let Johnny back into the classroom unless he has medication.
Does she have a legal right
She
to do
does
that?
not, and has no basis for saying that. And it can be apparent to the visitor to classrooms with children on drugs that they do not have the spontaneity, they do not have the typical exuberance of normal children. And this brings up a point that hyperactivity as a symptom is not infrequently mislabeled and misconstrued in the face of just normal, exuberant, healthy behavior. So we have a compounding of the problem where the person making the value judgment, say the school teacher, can perceive a vigorous, enthusiastic, exuberant little boy as hyperactive when he's perfectly normal.
I want to get back now to the doctor's office. We have this child out of the classroom now and in a doctor's office. What does a medical evaluation typically consist of? And I'm not asking about your own work, but how it's usually handled.
Well, let's put it in the framework of time. The usual GP or busy pediatrician will see between, say, 40 to 60 patients a day. We don't have an hour evaluation. Typically you don't have even a half-hour evaluation. More likely, the attention paid to this issue is between 10 and 15 minutes. The 10 or 15 minute exposure to a child with a subtle symptom is not adequate. When there is a subtle symptom, such as behavior as a function of central nervous system imbalance, the diagnosis only comes by equally subtle techniques and pursuit by the physician who will take the time to ferret out the problem.
Let's back up a little bit. You said there are potentially hundreds of possible underlying causes for the symptom that we call hyperactivity. Tell me what some of the more common ones are in your experience. Let's start with the purely medical, physiological ones.
All right. In my experience, the metabolic issues, which can either be a function of deficiencies, genetic aberrancies, such as predispositions for various types of endocrinopathies.
What's that mean?
Well, endocrine dysfunction.
Okay. Some kind of hormone.
Hormone abnormalities. And or toxicities are the most frequent in my experience.
Toxicities meaning like lead poisoning?
Lead poisoning, additives in foods, hypervitaminosis of A, D, E, and K.
Too much vitamin?
Too much vitamin. I had a classical case of an attentive mother who was giving her daughter massive doses of vitamin A and liver, and she indeed did demonstrate hyperactivity, which was corrected once we determined the toxic levels of the vitamin A and decreased the vitamin A.
You also mentioned metabolic disturbances. What would one of those be?
Okay, certainly the most critical in the central nervous system would be carbohydrate metabolism. And those are the type of things such as juvenile diabetes, certainly the many variations on the theme of diabetes, such as not only low blood sugars, but blood sugar variations because of liver dysfunction, of adrenal gland dysfunction, of thyroid dysfunction, all of them influencing the carbohydrate metabolism.
Can some of these disorders be treated just by diet control of some sort, eliminating or adding foods?
Certainly, if there are certain critical blocks, say if a child doesn't handle one or the other foodstuffs properly, or shows a sensitivity to, say, a refined kind of material which has additives in it, certainly by eliminating that from the menu as a challenge to its cause-effect relationship will frequently result in a correction of the problem.
If it's a carbohydrate problem, that means that the brain either isn't getting or utilizing sugar properly? Is that right?
The brain has a pivotal dependence on carbohydrate or glucose levels. It is the major source of energy for the nerve cell in the brain, second only to oxygen. But the proper level of the glucose, which is arbitrarily set at 70 milligrams percent, has to be maintained or the energy to the nerve cell will not be available. So if it is too high, then there are other breakdown products which will also interfere with the nerve cell functioning. But if it's too low, which is really much more critical, the brain cell essentially is starved and will malfunction.
I see. Now, you mentioned also oxygenation, the supply of oxygen to the brain. What sorts of disturbances can cause that kind of condition?
Well, certainly everyone is aware that anemia is a cause of decreased oxygen. If there aren't enough red blood cells, the oxygen will not be carried in the proper amount to the various parts of the body and the brain specifically. Of equal importance, though, is the normal functioning of the heart, the pump that produces the pressure that allows the blood to be pushed around the body. So the heart is a very pivotal part of the oxygenation chain. And again, in my experience, it is not infrequent to find a child who is having either learning difficulties or so-called hyperactive symptoms to have a cardiac problem, a murmur, or a congenital heart difficulty, or in the older age group, certainly rheumatic fever and its cardiac implications is not infrequently a cause. One outstanding example in my experience is approximately 4 years ago when I first entered private practice. A little girl was brought to me who had been seen by at least 10 other physicians in the community and indeed labeled as schizophrenic and autistic. Unfortunately, the previous neurologist that she had been taken to didn't avail himself of a medical examination, let alone a neurological examination, and the parents related the fact that he, from across the room, established the diagnosis that she was a schizophrenic, which is, of course, a psychiatric diagnosis, and he was a neurologist. Upon examining this little girl, she demonstrated a number of very interesting physical signs. The most outstanding was the fact that she had a murmur, but also in the neurological examination, careful inspection of the back of her eye revealed very engorged retinal veins, which had been observed by ophthalmologists in previous years and called pigmentation, which in our laboratories on photographing and enlarging revealed that they were not pigment, but indeed engorged vein with bluish, deoxygenated blood circulating.
Now, so, they were engorged. Why?
It's not infrequent when there is a congestive type of failure in children that their retinal veins will engorge in terms of the cardiodynamic imbalance.
So it was not an eye problem, but the eye was a nice little window to view the veins.
As it frequently is.
And the veins were engorged because of cardiac problem.
Right.
And the cardiac problem
was the most profound thing, and finally we were able to get the little girl catheterized in terms of making the specific diagnosis of what the murmur was caused from. And indeed the murmur had been heard about a year before and considered functional by a pediatrician, and functional meaning that it was benign. Well, indeed this was not a benign murmur.
So all the signs were there, but
if they would look. They're always there if you look for them.
But they hadn't been put together.
They had not been put together. But the exciting part of this was this little girl finally got the specific diagnosis for her murmur, which was called a patent ductus arteriosus, which is a vestigial vessel connecting the heart and the lung. The surgery is rather simple in that they ligate this vestigial vessel.
Explain to me what does ligate mean?
Well, they tied it off.
Oh, I see.
That everybody has this ductus arteriosus when they are in utero or being carried by their mother, but once they're born, it gradually decompresses and the blood that has been going through there goes the other route.
I see.
So at any rate, she had this surgery and her hyperactive behavioral problems melted away. The engorged vessels in the back of her eye returned to normal, and she is presently, I think she's in the 3rd grade now, in a normal school setting and performing above average.
But her problems were because the oxygen was not reaching her brain.
That's right.
What would have happened to her if she had gone on diagnosis as schizophrenic?
Well,
aside from the psychiatric consequences.
The natural history of undetected patent ductus arteriosus is death by age 9 or 10 of congestive failure. But this sounds like a very isolated case, but it is not an isolated case, and I'm sure it's being missed and reduplicated hundreds of times throughout the country because of the tendency of physicians to be rushed, to not pay attention to the subtle signs, and these are the mistakes that are being made and compounded.
And can be fatal.
And are fatal.
Any other common medical causes? We've mentioned metabolism problems and oxygenation problems.
Certainly infection is as big an issue. Several interesting types of infection. Certainly the child who gets sleep deprived and irritable and angry because he has pinworms that he picked up from the family dog is not an infrequent finding. And again, you have to almost think of the diagnosis before you can make it. And so you don't pick up the subtleties about the family living in a 10 or 15 minute conversation unless you're thinking about it. Certainly other types of infections such as streptococcal and rheumatic processes secondary to streptococcal infection. Usually this doesn't occur until after age 5 or 6, however. Other types of infections, certainly brucellosis is still around.
Brucellosis.
This is the undulant fever or the cattle-bearing kind of bacterial infection, which can also affect the heart, which then by itself can either through the heart dysfunction or in and of itself produce central nervous system effects.
So what you have is some sort of primary physical problem which is producing sort of a secondary effect on the behavior of the child.
That's right. Then if you look at it in terms of the behavior as a symptom of the not normal functioning brain, then you ask the next logical question, well, why isn't it functioning normally? And you have to get an answer. And there's usually a cause and effect relationship.
How long does it take to get an answer?
Well, it depends upon how elusive the diagnosis might be. Certainly in the instances where I see children with this symptom or complaint, it takes me about a day and a half. Certainly the first portion of it in histories and physicals in the morning is the major part, but then the characterization of neurophysiologic processes take usually the afternoon, and then the biochemical studies in the next day, which take 5 hours typically.
Now this is 1 to 2 days of a specialist time. I'm sure a lot of parents would wonder about the expense of such a procedure.
Well, the insurance companies, in my experience, pick up the tab readily. The insurance company typically finds it's much less expensive to have a definitive diagnosis under one office visit rather than having the child going periodically for 15 or 20 minutes office calls without a definitive diagnosis and then still being liable for a major illness 4, 5, 6 years later.
Yeah, typically, hyperactive children are under treatment for years, aren't they?
That's right.
Whereas you're saying that if you can get that problem defined early and taken care of, you can avoid
They don't have
years.
to have the handicap or the irritation or the imbalance. The time is taken to determine what that imbalance is to cause the symptom.
Now you see some fairly severely hyperactive children. Would you say that in most cases, or almost most cases, one can get to an etiology and define exactly what's wrong with the child?
Well, let me put it this way. There is very little today that is undiagnosable. It is mainly not diagnosed.
That sounds so much more optimistic than what you usually read about hyperactivity, where they're very pessimistic about getting to the root.
Well, they made up their mind before, probably, that they're dealing with the hyperactive syndrome, which is a misnomer to begin with, rather than looking at it as a symptom. But if you take the position that there is very little that is undiagnosable and pursue the symptom complex with that philosophy, it's very, very rare that I don't find an etiologic cause and effect relationship for the dysfunction. Sometimes, and it's not very often, but sometimes the diagnosis is not remediable. For instance, say if there is a tumor, if there is a thrombotic vessel or something that cannot be repaired, that is one thing. But that is much more the exception than the rule. And usually there is a treatable, diagnosable issue in hyperactivity. And the child is able to make a complete about-face and get on with the process of learning, living, and participating happily in a family.
It makes one feel very sad and upset about all the hundreds of thousands, if what we read is true, children out there.
It's frustrating, but for me it's a very exciting and rewarding pursuit, because subtleties have a subtle explanation, and it is a very precise kind of an approach.
Let's talk a little bit about psychiatric origins. We've talked about purely physiological or biochemical origins. What sorts of psychiatric causes can there be?
Let me just characterize it in this way. To opt to a psychiatric diagnosis, first off, in my opinion, is an error. And the psychiatric explanation should not be made by default, that a child can have both a psychiatric and a physical explanation for the hyperactivity. Diagnosis psychiatrically should come from positive emotional developmental history or situational data that the doctor knows exists. So from that, you can say some of the children's psychiatric decompensations are somewhat age determined. For instance, the young boy between ages 4 and 7 may well be still going through an Oedipal struggle. He may not have had a resolution of his mother-father identity relationship, and on the basis of that be a problem both at home and at school because of it. This can be easily sorted through in terms of positive history about the little boy's attitude towards mother and father, and it is typically very easily treated by, if it is a little boy with an unresolved Oedipal problem, to prescribe a higher dose of father. By that I mean suggest that Johnny and his daddy do more things together, physical things, wrestling on the floor, going fishing, playing football. So Johnny gets it through the nonverbal message that he is not going to overcome daddy and whip away with mother. Same thing applies for little girls in the Electra phenomenon, much less frequent. Other situational phenomenon, though, that can profoundly affect children is, say, the presence of a provocative parent, certainly molestation by the opposite sex, certainly conflictual home situations such as divorce or imminent divorce or witnessing abuse of one parent to another. So there are many psychiatric issues, but they can only, and I feel they should only be made with positive data. That to not make a physical diagnosis or a medical diagnosis does not then automatically put the child in the hands of a psychiatrist by default. It has to be specific reasons for the child to have an emotional issue.
I see. So you just don't put everything in some sort of psychiatric wastebasket.
That's right.
Well, then there are lots and lots of potential physiological, biochemical, and psychiatric and situational causes, everything from some sort of real brain dysfunction to pinworms. And yet the treatment of choice in recent years has been only one treatment, usually one treatment, and that is stimulants. Why are stimulants prescribed, and what do you think about that?
Well, the proponents of stimulants are unable to explain how they work. They are used today on an empirical basis. It had evolved some 30 years ago that some physician happened to give a child amphetamine drugs, which should typically stimulate the child and in and of itself produce hyperactive-like behavior, and he found a paradoxical reaction that it sedated the child. And it's from then on that amphetamines caught on, and they were used to sedate children. Subsequently, Ritalin came into vogue, and it helped to also sedate certain children with the symptom of hyperactivity. The empirical use is, as far as they've taken it even today in 1974, the world literature does not cast much more information about its reason for working. It does explain other things about amphetamines and Ritalin, and several of those are that they do indeed affect growth hormone produced by the pituitary, which is a central effect. So that implicates the central action of amphetamines. We do know that amphetamines and Ritalin produce a detrimental imbalance of the sensitive biochemical amine system in the brain. And indeed, in adults, more recently, they have, the radiologists, the neuroradiologists, are referring to what they call amphetamine brain. Amphetamine brain is the atrophy of the ventricles, the holes in the brain, to an extent that they can determine that a patient has been on amphetamines by the amount of atrophy of the brain. It certainly does influence the carbohydrate metabolism. But it is, again, ludicrous to give a drug to influence carbohydrate metabolism unless you know that the carbohydrate metabolism needs influencing, and in what degree and in what way, and use the appropriate thing. Other people have said that the amphetamines were used as a mild anticonvulsant for subclinical seizure, but again, it's ludicrous to use something that might be influencing subclinical seizure unless you know that it is indeed there, and then use the drug of choice. So it's an empirical drug, it's a dangerous drug, and in my opinion has no business being used on little children for symptoms which may have any number of other explanations, and particularly on little children who don't have the right to make the decision whether they're going to take it or not, who may become addicted to that drug by the parent fostering it on them, and who may indeed develop not only a dependence but a brain atrophy from it years later. I think we've been playing with fire. There are people who propose the drug and they are so vehement and outspoken about its use that they can't be objective about it. They cannot say, well, maybe we should take another look at it. The papers that I see in the literature, they pay lip service to the careful evaluation, but when you look at their series, they've not even evaluated the child, and they've already made up their mind that they were going to use Ritalin to begin with. Mm-hmm. So we have to have objectivity, I believe, and we have to avoid bias and have your mind made up of what you're going to use before you make the diagnosis when you see a patient with this symptom complex.
So you never prescribed?
I have never used or written a prescription for amphetamine or Ritalin for a child with so-called hyperactive symptoms. It's never been necessary. It's never been indicated. There has always been a cause and effect relationship which is diagnosable. It's very exciting sometimes, the diagnosis that comes out. I must say I have taken probably hundreds of children off Ritalin who have been taking Ritalin for years, and they have not needed the Ritalin after we made the specific diagnosis, and that's an exciting event too.
When these children are on Ritalin for years, do they develop a tolerance?
They can develop a tolerance.
Or other, I should say, or other amphetamines like
yes.
dextroamphetamine.
And certainly the literature reflects that there is a dependence that can be developed, and there is a withdrawal. And there is certainly an appetite suppressant. Pardon me?
Even with small amounts? I know if you're a speed freak, then it's known that there are withdrawal symptoms. Are there withdrawal symptoms when you're on a medical dosage also?
Well, typically the so-called medical doses has been escalated to the point where it's no longer a small amount. But then you're also talking about a little person who takes doses of, say, 10 to, say, up to 100 milligrams a day of a medication, which an adult wouldn't really bother, but in a child it will. But also you have to extrapolate that if this medication has been taken chronically for months to years, that its imbalance in and of itself in terms of the bioamines of the brain, the carbohydrate metabolism, the growth hormone effect, and if it's suppressing seizures, if it's taken away, it's going to produce an effect. It's going to leave its imbalance in its wake.
Yes, I see what you mean.
And leaves its footprint, certainly in terms of small vessel constriction and atrophy of the brain in certain people.
I meant to ask you before, but I forgot. What happens to the child after childhood, the hyperactive child in adolescence and adulthood? Do we have any idea? Is this really a passing phase?
One interesting study has been done about, say, the misdiagnosed hyperactive child who had mixed dominance. Children with mixed dominance are those who have difficulty with reading and writing, reversing, and who are typically rather bright, but are labeled as retarded. Now, these children in adolescence tend to be actor-outers, tend to get in trouble with the law, and frequently a large percentage of the juvenile delinquents are these children. So either they're curtailed by the juvenile authorities, they might gravitate into a life of sociopathic behavior, or some of them revert into doing menial jobs, way out of way below their intellectual capacity, truly.
Could that be because of the emotional reaction that they're having to the learning problems and the frustration?
That's right. That is the theory.
Now, mixed dominance is a physiologically based problem. That is because one part of the brain doesn't assume dominance for language functions and so forth. Can that be treated?
Very definitely, if it's caught early. Again, there are another very important rule of thumb in medicine is that early diagnosis is key, and particularly in mixed dominance. To diagnose the child, and typically it's a little boy, before age 6 or 7, it is completely treatable and resolvable. If the diagnosis does not come until age 11, 12, or 13, it is not treatable. We typically will try to treat it, but it cannot be resolved. and the patient is pretty much lost to treatment.
That's because of changes that are occurring in the brain?
Well, that again is the theory that the pathways have myelinated sufficiently that the alternate pathways or the relearning is much more difficult.
What does the therapy consist of?
Well, it's an educational specialist type of therapy. It is referred to as training the child to code and encode. It has, it's typically, in my experience, best done on a one-to-one basis with a sophisticated, sensitive reading specialist teacher who has specialized equipment such as cystoscopes and various educational materials which help the child to establish a right-left orientation and ability to code and encode symbols.
Well, this is obviously a very complicated thing that we're talking about. What should a parent with a hyperactive child expect then when he takes his or her child to the doctor with a suspected hyperactivity problem? What would you counsel parents to do if they think they have a hyperactive child?
I think any person, particularly a parent, should not be in awe of the white coat. They should ask questions and ask the doctor to explain himself in terms of his opinions. And if the parent is not satisfied with the explanation, if they feel that the physician has done a once-over-lightly job, if they are sent away with a prescription and not having had a careful medical, neurological, neurophysiological, and biochemical evaluation, they should say, well, maybe he didn't ask all the questions. Maybe there is something else going on.
Well, now, not all doctors are Marcus Welby. This means really that there has to be a different kind of relationship than the one that often exists between a patient and a doctor, where you get sort of this big authority figure up there, and the patient or the patient's parents are not really called upon to aid in the diagnosis.
That's right.
You think patients should be uppity?
I think patients should demand a value for their medical dollar. I think that they should, first of all, try to establish some basis for comparison, and in comparative shop. They should have, maybe even talk around. They should find out who the physician is that spends the time, who has the training and credentials, who has a track record of knowing what's going on in this area, who will satisfy their questions and not just be arbitrary in saying that he has all the answers, because no physician has all the answers. And if the parent cannot get an adequate explanation from the physician, it's probably because he doesn't know and should be referring that child to somebody that does know. Now, unfortunately, people think that the pediatrician is the last word about children's diseases, and again, I must emphasize, they are general practitioners for children. They should be referring neurological problems, hyperactive problems, psychiatric problems out of their practice to the specialist. They do not do this, and this is an error.
Dr. Walker, could you give us sort of a little thumbnail sketch of what does constitute a satisfactory approach or evaluation of a hyperactive child?
All right, I would draw on the classical medical model, which is an exhaustive evaluation of the symptom in terms of time, frequency, degree, and other symptoms that might go along with it. Try to characterize in that present illness what goes on in a 24-hour day, his sleeping, his eating, his bowel habit, and all. Then a developmental history. Developmental history must start prenatally, 9-month gestation, during the delivery. Try to get the birth records, the APGAR score, the postnatal period, and then the developmental landmarks through sitting, standing, walking, talking, declaring of handedness, and whether or not the child practiced pica. You must get an inoculation history and a temperature history. Then you do a
What's the temperature? You mean during the day, the 24 hours?
No, the history of child having high temperatures and what is done and when they occurred and were there febrile seizures.
I see.
Then the past medical history, which should outline and put into perspective all infectious diseases, all hospitalizations, and all other value judgments about that child's health by other physicians. Did they have heart disease? Did they have liver disease? And on and on. Then the family history, which should be an exhaustive characterization of all the family members, plus the diseases and infirmities of grandmothers, grandfathers, uncles, aunts, and cousins. Then a social history, which is frequently that one of the culprits of, say, toxic exposure, what kind of heating in the house, what kind of pets at home, what kind of hobbies are practiced. And those areas will frequently bring up some of the subtleties. Then you start all over and must do a careful review of systems, and this is going through again the asking questions about head, eyes, ears, nose, throat, heart, lungs, and all the way through. Then a careful general medical examination with quantitation of all vital signs and measurements when possible of head size, weight, and height. Then a careful mental status, a careful neurological examination. Then after those portions are done, then a biochemical profile, and not just all known tests, but establishing, is the child anemic, is there intercurrent infection, is there a proper calcium phosphorus level, is there a normal electrolytes, liver function, kidney function, and in some instances maybe steroids are necessary, or other more esoteric biochemical studies. Then once you have all this data, you're able to make a value judgment with a multi-phasic, multi-dimensional basis.
I can see why it takes 1 to 2 days, because it's, I imagine that as you go through this procedure, the data that you begin to get back, for example, from the history and so forth, might direct the later stages.
That's right. That is
so
exactly
you might not
right.
have to, in fact, run every conceivable
That's right.
test.
Everybody doesn't have
You don't have to do a shotgun approach, but rather these are all...
shotgun approach is an error, and I think that has been the error to begin with.
Well, then, to sum up, the moral is that we ought to be much less cavalier than we have been about hyperactivity. Thank you, Dr. Walker, for talking with me today.